All right, everyone. So we are on page 115 of your study guide. So now that we are beginning Med-Surg, it's very, very important for you to know that at the beginning of each chapter is a page that looks like this, and it's going to say topics covered. So these are the most important topics for you to make sure that you have read and you understand for this chapter. So this is an NCLEX review, so I'm going to touch on the most important things that I know for a fact, without a doubt, you have to know for the NCLEX. However, we can't go through each and every sentence because then we would have to be here like 8 hours a day, 5 days a week, right? And so my job is to make the information as easy to understand so that you can study more effectively. So you have to make sure that you are reading the entire chapter, and you have to make sure that you are going through this checklist and that you have at least read through all of these topics. So these are the major systems of Module 4. Module 4 is very complex. You have adult neuro, you have eye and ear, you have adult skin, and then you have perioperative. Okay, so it's a lot. You have to read the entire chapter. There's no other way. You have to read the entire chapter, and this list, which starts on page 115, you have to make sure that you understand every disease or condition that is on this page. If you do, you will be good to go for these body systems for the NCLEX. You will see questions like this, or you will see questions based off of this. Every student that I have had that has passed the NCLEX has told me the same thing, that what I put in the study guide helped them to answer questions correctly when they were taking the NCLEX. So please, please, please do not lose your advantage. You will have a greater advantage if you read the entire chapter. Okay, so adult neuro, let's get into it. Adult neuro starts on page 118. So it begins with just a basic review of the anatomy, okay? The anatomy and physiology of the brain. So you have three major parts. You have the cerebrum, the cerebellum, and the brainstem. Okay, cerebrum. The cerebrum is made up of 4 lobes. The cerebrum is made up of 4 lobes. The frontal lobe, parietal lobe, temporal lobe, and occipital. So the cerebrum is these 4 lobes. The orange, the blue, the green, and the yellow is called the cerebrum. The cerebellum is underneath it. And then the brainstem, it starts from the base of the brain, and the brainstem will connect with your spinal cord. Your brain and spinal cord make up your central nervous system. Okay? So, we're not going to get into details of what each lobe does because it's here and you can read it. I'm going to more focus on what is going to be on your NCLEX. Okay? Now it talks about a portion of the brain called the hypothalamus. The hypothalamus, I want you to memorize these 2 bullet points here. The hypothalamus, it regulates what is called autonomic responses. When you see the word autonomic, I want you to think automatic. Autonomic, automatic. Autonomic responses includes sympathetic nervous system and parasympathetic nervous system. I want you to memorize that when you see sympathetic nervous system, I want you to think fight or flight. The two hormones associated with fight or flight are epinephrine and norepinephrine. The other name for epinephrine is adrenaline. The other name for norepinephrine is noradrenaline. So we're going to learn more about that when we get to module 8 for endocrine. But I do want you to memorize this now. You have to understand that the sympathetic nervous system is going to cause an increase in your blood pressure. And this is associated with like a state of stress. Then you have the opposite, which is the parasympathetic nervous system. This is more like your body is in a relaxed state, and we call this one rest and digest because your body is at rest here and you're digesting food, you're not stressed out. And the hormone associated with this is acetylcholine. Okay. Next, I want to make sure that you read and understand about the brainstem. The brainstem has two major portions, the pons and the medulla oblongata. The pons contains the respiratory center and it regulates your breathing. The medulla oblongata controls your heart rate and also your breathing. It also controls the diameter of your blood vessels. So when we get to cardiac and we start talking about vasoconstriction and vasodilation, we're talking about the medulla oblongata and how it affects the diameter of the blood vessels. So these are things that you have to read and understand. Okay, you cannot bypass or shortcut those. These are foundations for you. Next up is the spinal cord. So give me a moment and I'm just going to open up a picture for you. Oh my goodness. You guys could, I didn't know I was on mute that whole time. Oh my God. I've been talking forever. I'm so sorry. It's just now I'm realizing. Hold on. Guys, what was the last thing you heard me say? I'm so sorry. I apologize. I've been talking this whole time. My goodness. Can someone put in the chat what was the last thing they heard me say? Oh my gosh. Okay, so let's just go back a little bit. Okay, so this picture here, it shows you your neurological system. So the neural system consists of the brain, the spinal cord, and the nerves. Okay, can everyone hear me well? Okay, good. All right. So what I was saying is the spinal cord is how the brain receives and sends information. And the nerves are like the little highways, okay, that send the messages out to the body, okay? So, again, make sure you know that the brain, the spinal cord, and the nerves are what make up the neurological system. This is another picture of the spinal cord so that you can see. And remember, the spinal cord, it connects with the brain stem. Okay? So, the spinal cord has different regions, and those regions are named based off of their anatomical position in the body. So you have the cervical or C spine, the thoracic or T spine, the lumbar or L spine, and then the sacral or S spine, and then the coccygeal. So what I wanted you to know also is that there are bones that protect the spinal cord, which are called your vertebrae. Okay? And the spinal cord is located within the vertebral canal. So can somebody tell me why do you think that the spinal cord is surrounded by bones? Why do you think that's so important? Very good. Very, very good, Nurse Daphne. Yes, protection. Protection from what? What's the big deal? Protection from injury. I mean, so are you trying to say that damage to the spinal cord could lead to death? Very good. Yes, absolutely. 100%. So damage to the spinal cord could lead to paralysis. Damage to the spinal cord could lead to death. The higher up a spinal cord injury is, the more likely it is to be fatal. So, when I say that, which one do you think would be more dangerous? Do you think an injury to the L spine would be more dangerous, or an injury to the C spine? The C. Okay. And because didn't we say earlier that the medulla oblongata and the pons, which are located in your brain stem, right? The medulla oblongata and the pons are located in your brain stem. And they control what? What do the medulla oblongata and pons control? You're breathing. Very good. You guys are on it. Very good. And so the higher up a spinal cord injury is, the more likely it will affect the respiratory center of the brain, and it's more likely to lead to respiratory failure. Okay? So injuries at C2 to C3 are usually fatal because they damage the breathing center of the brainstem and can lead to respiratory failure. All right. So we spoke about how the spinal cord carries information to and from the brain. So the nerves of the body receive information, okay, and they make your muscles have a movement. For example, if you touch a hot stove, you have sensors in your fingertips that can sense heat. They send this information of this temperature through the nerves of your fingers up your arm into the spinal cord. The spinal cord sends the information to your brain. Hey, our person is touching something hot. The brain sends a signal to the spinal cord, back to the nerves, to the muscles of the arm to make you move your hand. This is what we call a reflex arc. So this is a perfect example of how the brain can receive information and send feedback. And how long does that take? How long does it take when you touch a hot stove for you to pick your hand up, for you to move your hand away so quickly? Seconds. Faster than you can blink your eye. You go, ow! Oof, that was hot, right? You don't have to think about it. You don't have to nothing. It happens so quickly. Do you see how amazing your brain is? Your brain is fascinating. And what do you think is the overall goal? Why do you think your brain wants you to move your hand away so quickly? I'm telling you, God is amazing. Why do you think your brain wants you to move away so quickly? I mean, it happens so quick. You don't have to think about it. It takes me longer to explain the process with my words. It takes than for it to actually happen. It happens so quickly. Why do you think your brain does that? Why do you think your brain cares if you're touching a hot stove? Do you think that your brain wants to protect you? Yes. Your brain is constantly looking for ways to promote your survival. What are some other ways that your brain promotes survival for you or protects you? So do you think after you, and let me put a picture up for you, but do you think after you touch that stove, do you think you're going to be a lot more careful the next time? Right? You're going to be like, you know what? Next time, let me be a little bit more careful. Because do you think that your body's trying to protect you from injury? Your body's naturally trying to protect you from injury, right? And as a result of touching that hot stove, do you think that which autonomic nervous system do you think is going to be stimulated in that situation? Do you think the sympathetic nervous system is going to be stimulated or the parasympathetic nervous system? Okay, I have a question for you. After you touch that hot stove, is it your heart gonna be beating fast? Hello. That's sympathetic. That's sympathetic nervous system. That's fight or flight. Now your body has experienced some type of pain or injury. Your heart is beating faster. Your blood sugar is going to increase. Your blood pressure would increase. This is your body's way of saying, hey, wake up. We don't want you to get hurt. Can somebody give me another example of how your brain is constantly fighting to protect you from yourself? Do you think when you're afraid of something, do you think that's part of your body's way of protecting you? Oh my gosh, you go girl. Yes. She said if you see a snake, absolutely. So, in a way, when you're afraid of something, do you think that could be your body's way of trying to protect you from something? For example, like, do you think being afraid of snakes, do you think that that could be your body? Okay, why? Why would that protect you in a way? Because you're probably going to stay away from snakes, right? So your brain is more powerful than you think. And we could talk about this forever, but my goal here is to make sure you pass the NCLEX. But your brain is constantly protecting you from danger, and you don't even know it. And it's so quick that we take it for granted all the time. So let's look at just one more picture on this. So this is a reflex arc. In this, they call it a reflex action, but it's an arc because it's like a feedback system. Okay? So first, the person accidentally touches a hot object. It's going to send the information up through the spinal cord. Here's the spinal cord here if you were to cut it in like a piece, and the nerves are going to send the information to the spinal cord. The spinal cord is going to send the information to the brain and say, hey, the thermal receptors in the fingertips of our person has touched something too hot. The brain is going to send a signal back down the spinal cord through the nerves. The nerves are going to innervate the muscle, and the muscle is going to lift the hand up. And you not only do you have thermal receptors, thermal means heat, so you have thermal receptors in your fingertips and all over your skin, so that when you touch something too hot or too cold, it activates you, it stimulates you, right? And you also have pain receptors. So pain is your body's way of saying, stop that, stop it, whatever you're doing, it can hurt you, so get away from it. Isn't God amazing? Because without the pain receptors, you would leave your hand on that fire and that person could burn their hand. And we're going to learn when we get to skin that burns can lead to infection and sepsis and death. And the pain receptors are your body's way of saying, whatever you're doing, get away from it. We don't want you to get hurt more badly. Okay? So the body is amazing. Never take your brain for granted. Okay? So we've learned about the main functions of the spinal cord, but here are some other things that you didn't know about. Okay, so the spinal cord is protected by the meninges. You have 3 of them. The spinal cord is also protected by cerebrospinal fluid. So you have fluid that is constantly circulating around your brain and spinal cord, and then back up the spinal cord and around the brain and down and up. And so you have cerebrospinal fluid. So what's protecting your spinal cord? You have the meninges. You have 3 of them. You have cerebrospinal fluid, you have fat tissue, and also we learned about the vertebrae, the vertebral canal, which is also protecting the spinal cord. So let's learn about the meninges. You have to know the name and you have to know the order because that will help you understand where certain injuries or conditions are happening. So why do you have to know the meninges? Have you ever heard of meningitis? Meningitis is when they get inflamed or have an infection. You have to know the names: dura mater, arachnoid, and pia mater. Dura. What does that mean when something is durable or dulab? What does that mean when something is very durable? It's very tough, right? And mater means mother, mom, mother. So the dura mater, it literally means a strong or tough mother. So it's the first one, it's the first meningeal layer. Okay, but a lot would have to happen for someone to get brain injury or spinal cord injury. So protecting the brain, first off, you have the skin. You have hair too. You have hair, you have skin. Then you have the skull. The other name for the skull is the cranium. Then you have periosteum, which is on top of the skull. Okay. Then we have the meningeal layers. So you have hair, you have skin, you have the periosteum, you have the cranium, then you have the dura mater. Then you have the arachnoid matter. Then you have the pia matter. So from outside to in, DAP, DAP, dura arachnoid pia. So why do you have to know these things? So if somebody says epidural, the patient received an epidural. Okay, they say epidural all the time, like OB patients giving birth, right? She received an epidural. So epi means on top of, correct? Okay, so when you see the word epidural, an epi means on top of or above. So when a patient receives an epidural, that medication is on top of the dura mater. It's not underneath it. The needle that they're using to insert into the spinal canal is on top of the dura mater. Okay? Then sometimes you might hear some people say the patient has a subdural hematoma. So what does sub mean? Below. Excellent work. Excellent. So below or underneath the dura. Okay. So if a patient, God forbid, falls and you being let's say you're working at the nursing home, that was my first nursing job, and a patient, God forbid, falls, and you suspect that they hit their head, and you let the doctor know you're responsible, and you say, doctor, I do believe there's a chance this patient has hit their head, and the doctor says, okay, let's call an ambulance and have them sent to the hospital so they can do a CT of the head and rule out brain injury. And then they do the CT of the head and they say the patient has a subdural hematoma. Are they bleeding on top of the dura or underneath it? Underneath it. Very good. Or a patient can have a subarachnoid hematoma. So would the subarachnoid hematoma be underneath the green dot or underneath the blue dot? A subarachnoid. Would a subarachnoid hematoma be underneath the green dot or underneath the blue dot? Underneath the blue. Very good. So subarachnoid hematoma would be underneath the arachnoid layer. Okay, very, very good. So dura matter, arachnoid, and pia matter. And the pia matter is in direct contact with the brain itself. So as you can see, and then on top of that, you have the cerebrospinal fluid circulating, you have fatty tissue, so you have a lot of protection. So when somebody gets traumatic brain injury, that trauma or the force of that trauma must have been very powerful to overcome all of these anatomical obstacles your body has in place to protect your precious brain. And then one more thing, because I'm Haitian and I'm dramatic. I can only be myself. The brain is so powerful. You have the power. Just 1 minute, I promise, and then I'm going to shut up and get back to NCLEX, I promise. The brain is so powerful. You have the power to make your whole destiny change with one word. Remember that the brain is more powerful than you think. In the Bible, God created the whole universe, and He began it by saying, "Let there be light." With His words, God created the universe. With your words, you can make what you want to come true. So if you say, "I will pass the NCLEX on this day, when I go take it, I will pass the NCLEX," and if you believe it, it is so. So I just want to let you know, you are more powerful than you think. Remember that. All right. So spinal cord, meninges, we've learned about them. Cerebrospinal fluid, you should have about 125 to 150 milliliters of fluid called cerebrospinal fluid. It brings nutrients and it removes waste. It is a protective cushion. So whenever there's fluid surrounding something, like when the fluid is supposed to be there, it protects that organ or whatever it is, okay? Like you have a little bit of fluid around your heart called a pericardial fluid. It helps to protect the heart a little bit. It absorbs shock. And you have cerebrospinal fluid around your brain and spinal cord. It serves as a little cushion and it brings nutrients. And it runs through the subarachnoid space. So cerebrospinal fluid, you would find it underneath the arachnoid, underneath the blue area here, you will find it circulating. However, remember this. Wherever there's fluid, it has to have a balance. We just learned it should be 125 to 150 mLs. What do you think could happen if there's too much fluid? Ooh, I'm telling you, this group is going to pass. This group is going to pass. Pressure, right? Like, for example, let's say you drink a lot of water. Like, okay, let's say you drink a normal amount of water. You probably feel normal, fine, nothing, go about your day. But let's say you drink like 2 liters of water in the morning. Are you going to feel, when it's time for you to go use the bathroom and urinate, are you going to feel that pressure in your bladder? Are you going to feel that pressure of that excess fluid? Like, oh my gosh, I have to use the bathroom now, right? So wherever there's a buildup of excess fluid, it's going to create a pressure. And this is going to get into probably one of the most important topics of this body system. And it's fascinating every time I learn about it. But look at this picture here in front of you. Do you see that there would be a lot of room here for excess anything? Or doesn't this look pretty tight to you? I don't see a lot of room. If there's already supposed to be 125 to 150 mLs of cerebrospinal fluid, I don't, that would be here filling up the subarachnoid space. I don't see if there was like excess fluid or blood that shouldn't be there. There's no room for expansion here, correct? And if you just tap on your skull, it's pretty hard, right? So when we start learning about cerebrospinal fluid and a buildup of pressure, which is called increased intracranial pressure, you're going to learn why increased intracranial pressure can be so serious because there's not a lot of room for the excess fluid to go. Your skull is a pretty tight compartment. There's not a lot of room. Your skull is not like your belly. Your belly, your stomach can expand, 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 expand. The cranium, it can't do that. So when we have brain injuries that cause swelling or brain injuries that cause bleeding onto the brain, it leads to some very serious problems because that excess fluid or blood is going to exert pressure. And that pressure, gravity, do you think pressure is going to press down or press up? Press down or up according to gravity? Where would the pressure press down on? Gravity would make pressure press downwards, correct? Very good. Downwards. Downwards onto the what? Downward onto the brain. You guys are very intelligent. And I mean that. Very good. Downwards onto the brain, correct? And how does the brain stay alive? It needs oxygen, right? What brings the brain oxygen? The cerebral arteries. You have arteries that are like in and outside of your brain, on your brain, weaved inside your brain, right? So that pressure, let's say that patient has too much cerebrospinal fluid or they have bleeding onto or around the brain. That pressure of that excess fluid or blood being there is going to press down on the brain. And when you press down on an artery, can it do what it's supposed to do? No. When you press down on an artery, you're blocking blood flow. And so we're going to have an area of the brain getting pushed down on that's not getting enough oxygen. And that area of the brain will become hypoxic, or some people say ischemic. And then if we don't reverse that, that part of the brain can die, right? So we're going to learn about that. And so that is the beginning of increased intracranial pressure and why it can be fatal. For homework, go through the cranial nerves. On the topics covered page, I put here which ones I recommend memorizing for NCLEX: 1, 2, 5, 7, 9, and 10. No way around it. You have to do it because these are very popular for the NCLEX. Okay? So cranial nerves on page 119, you see the ones I told you to memorize. Okay, page 120, diagnostic tests, x-rays. X-rays, also radio, also called radiographic imaging, okay? X-rays, radiographic imaging. X-rays reveal fractures, dislocation. It can tell you the size of a bone. There's little squiggly marks called sutures, and it can tell you if those sutures have separated. It can tell you if bone has broken down, which is called erosion, or if bone is abnormally hardened, which is called calcification. Okay? We don't recommend pregnant women to get x-rays because the radiation can harm the child. So, number one priority as a nurse before a patient has an x-ray to check if they're pregnant. Next up is a CT scan, okay? CT scan. It is used, or also called computed tomography. It is used to detect, so this is more for soft tissue. An x-ray is more for something hard, like bones, right? CT is more for tissue. So you can use it to detect intracranial bleeding, lesions, cerebral edema, infarctions, which would be stroke, hydrocephalus, which would be like a buildup of fluid, atrophy, which is like a decrease in mass of the brain, and also a shift. A CT can be with or without contrast. As a nurse, you have to memorize this. And this is in your study guide, by the way. I'll show you. Okay? So, page 120, CT. CT, it may or may not include the injection of dye. So, we call it contrast dye. Contrast dye would allow the doctor or healthcare provider to see the structures better. Number one, you need informed consent before giving contrast dye. Number two, you have to assess the patient for 3 allergies: shellfish, iodine, and radio-opaque dye. If the patient is allergic, you let the healthcare provider know. When the dye is injected, the patient may feel a warm, flushing feeling, and it may make them feel like they have to pee. I had a CT of my chest once, and I thought I was going to pee on myself, but nothing happened, but that's normal. Okay? Your last major priority for a patient getting contrast is if they are taking metformin, they have to stop taking it. Say it with me, 24-48. 24-48. So if a patient is going to receive contrast dye and they are taking metformin, they have to stop the metformin 24 hours before and 48 hours after. One more time, what do you need to know? A CT can be with or without contrast. If the doctor ordered it with contrast, you need informed consent. You have to verify for allergies to shellfish, iodine, and radio-opaque dyes. And if the patient is taking metformin, you stop the metformin 24 hours before, 48 hours after. Next up is MRI. MRI can be used to identify tissues, tumors, and vascular abnormalities like blood vessel abnormalities. MRI stands for magnetic resonance imaging. An MRI is a huge magnet. You must remove all metal objects before the patient goes in anywhere near the MRI machine. For example, any magnetic object can become like a bullet in the MRI room. So even you, before you go in, you have to remove anything metal. Earrings, jewelry, your ID badge, any pen you think that might, because when I say like it can fly through the patient's body, like it can fly through someone's neck. Your number one nursing priority for MRI is to remove all metal objects. Your number two priority is you're going to complete the MRI questionnaire with the patient. And it's going to ask the patient, do they have a pacemaker, a defibrillator, an implant or a prosthesis in their body, vascular clips, any bullets in their body from a gunshot wound. If they are pregnant, they probably cannot have the MRI because it can harm the baby. Okay. All right, guys. Let's take a 10-minute break. When we come back, I'm going to ask you some questions about what we just learned, and then we're going to continue on. Thank you so much. Guys, so let me ask you guys some questions. So please, everyone, participate. So what are the three major parts of the brain? Can somebody tell me what are the three major parts of the brain? So the cerebrum, the cerebellum, and the brainstem. Very good. And how many lobes does the cerebrum consist of? Four. So remember the cerebrum, very good. Four. You have the, what are the name of the lobe? The names of the lobes of the cerebrum. You have the frontal, parietal, temporal, occipital. Okay, so remember there's three major parts to the brain: the cerebrum, the cerebellum, and the brainstem. And the cerebrum has four lobes: frontal, parietal, temporal, occipital. Very good. So we learned about the autonomic nervous system a little bit because we learned about two major autonomic responses. We learned about sympathetic nervous system and then parasympathetic nervous system. So which one is associated with fight or flight? Sympathetic, very good. And what are the two hormones associated with the sympathetic nervous system? Epinephrine and norepinephrine. And what are the other names? What is the other name for epinephrine? Adrenaline, very good. And what is the other name for norepinephrine? Noradrenaline, very good. And believe it or not, we're going to see those again in module 8 for endocrine. We're going to see those for in cardiac. So those are some very, what we're talking about. This is the foundation of you being a strong, well-versed, competent nurse. This is the beginning of it. So memorizing these things is going to take you so far in your nursing career. Okay, so then parasympathetic nervous system, what's the saying? Do we say fight or flight, or do we say rest and digest? For parasympathetic nervous system. Very good. Rest and digest. And then what is the hormone associated with that one, with parasympathetic nervous system? It's not epinephrine and norepinephrine. It's what? Acetylcholine. Very good. Excellent. So what are the two parts of the brainstem that control breathing? We often call it the breathing center or respiration center or respiratory center. The medulla oblongata and the pons. Very good. How many meningeal layers do you have, and what are their names? You have three. Perfect. Dura arachnoid pia. Very good. So from outside to in, okay. Um, from superficial to deep, it's dura arachnoid pia. Very good. And then we learned about cerebrospinal fluid. You're going to memorize your cranial nerves. Okay, x-rays. What is your number one priority as a nurse before your patient has an x-ray? You have to make sure that they are not pregnant. Very good. CT, you have like three nursing priorities for CT. So, what's the first one? Okay, so very good. So your first priority for CT, and I may not have said this as clearly, so I apologize, but your first priority for CT is to make sure, is it with contrast or without? So let me just touch on this a little bit more because this is very important to keep your nursing license safe. So please remember this, okay? Um, when a doctor or healthcare provider gives you an order for a CT scan, they just might say, okay, do a CT of the head. Is that all you need? Is the order complete if they're like, okay, just do a CT of the brain? No. What else? What other piece of information do you need? You have to ask them, is it with or without contrast? Okay. So your number one priority for CT scan order is, besides the location, right, is to make sure that you understand, is that CT scan with or without contrast? Okay. Hi, Miss Luna. Oh, I didn't share the screen yet because I'm just asking questions to make sure everybody understood. Very good. So remember, your number one priority for CT is it with or without contrast? So then, let's say the doctor or healthcare provider says it's with contrast. Now, what are your nursing priorities? Very good. Very good. Okay, so allergies, excellent. Allergies to what? And very good, yes, informed consent. So, allergies to what? Three things: shellfish, iodine, and radio opaque dyes. Very, very good. And also remember, if it's a contrast dye, you need informed consent. Okay. And then now, if they're going to get the contrast dye, what medication do you want to make to check and see, like if they were taking or if they've been taking? Metformin. So I have a question for you. What is metformin for? What condition is that used to treat? Diabetes, right? Metformin is a diabetes medication. Um, do we usually give, and you might not know this unless you're an LPN, but it's fine. Very good. I love that. I love that, Nurse Annalise, how you said type 2 diabetes. Beautiful. Beautiful, beautiful, beautiful. Yes. Now, you may not know this unless you're an LPN, but do we usually give metformin in the hospital? No, we usually don't. So if a patient that has diabetes comes into the hospital, we put them on Accuchecks. And that means like every 4 hours or, like ACHS, before breakfast, before lunch, before bedtime. We check their blood sugars, and the doctor will probably put them on a sliding scale of insulin, and based off of what their blood sugar is each time, we will use the sliding scale to see how much insulin to give them. And the doctor will also order which insulins to put them on. Okay? Um, and everybody's different. Some people are on a low dose sliding scale because their blood sugars are somewhat controlled but just need monitoring. Some people are on a high dose insulin sliding scale because their blood sugars are very out of control. Now, so when somebody comes into the hospital, we don't usually give them metformin to control their blood sugars. We put them on Accuchecks, where we're checking it at certain intervals, and then a sliding scale, so that once we check it, if it's above 110, 120, whatever the sliding scale says, we cover it with insulin. And that's how we do it in the hospital. So what I'm trying to get across to you is, if they're getting a CT with contrast order, you're not going to see metformin on their hospital medication list. You're going to have to go to their home medication list. Okay? And then you're going to have to see. And then, so let's say you see metformin on their home medication list, and the doctor ordered a CT with contrast. What are you going to do next? You're going to ask the patient when's the last time they took it. You see? Also, you want to communicate that with the healthcare provider. Like, hey, I know you just ordered a CT of the head with contrast. The patient is a diabetic and takes metformin. They last took it yesterday at around 5 p.m. So then and everyone knows, okay, we have to wait until, if they took it yesterday at 5 p.m., we have to wait until today at 5 p.m. or later. That will be 24 hours without the metformin, okay? Another safe thing you can do, and these are just because as a nurse, you always want to try to like rule out any possibility of harm. And you always want to try to like just cover yourself as much as possible. When you get report, are you probably going to find out and report if the patient is diabetic? Yes or no? Yes, right? That's probably going to be one of the most important, probably one of the first things they're going to say when they get to the history section of the report. They're probably going to say the patient has a history of type 2 diabetes. So as you're writing your report, and if the doctor orders CT with contrast, and you're like, okay, let me make sure the patient's not on metformin. If you don't see metformin on the home list of medications, is there a possibility that the patient forgot to say metformin? Do you want to ask the patient, like, hey, I don't see it on your list, but I just want to make sure, do you take a medication called metformin? Right. And then if they say yes, then what would you do? Would you add it to their home medication list? Would you ask them the last time they took it and add that information in the home medication list? Would you then pick up the phone and call the healthcare provider and just say, hey, just so you know, I know you ordered the CT of the head with contrast for this patient. I just want you to know they are on metformin and they last took it at this time. How do you want me to proceed? And then after they tell you how to proceed, do you want to document what just happened? Okay. The other thing I want you to know, and make sure you write this down, this is going to take you far on NCLEX and for your nursing career. Contrast dye is very harsh on the kidneys. Okay, so we don't usually give contrast dye to patients with renal disease. So, NCLEX style question. If your patient is on dialysis, do you think that we're ever going to give them contrast dye? No. Okay, if your patient has acute kidney injury, do you think we're going to give them contrast dye? No, because we'll make the kidney problems worse. Okay? Um, and so you know the 24-48 hours rules. You want to stop metformin 24 hours before, 48 hours after. We don't give contrast dye to patients with kidney problems. We don't. But if we do give it to a patient, we want to encourage hydration after because we want to help get it out of the body. We want the patient to pee it out. Okay, remember, contrast dye is very toxic to the kidneys. So everything that the healthcare provider orders, it will be like weighing the risk and the benefit. Is the risk of us hurting the kidneys worth it to get this better image of whatever problem they're having with the CT so we can help them with that problem? They're going to weigh it out. Uh, what is your, okay, now we're on to MRI. Your number one priority for MRI. Contrast dye is very harsh on the kidneys. Okay. Another thing, and let me just put this on the screen for you. Hold on. And CT scan is so much. It's ridiculous. There's so much to, there's so many priorities you have as a nurse for a patient getting a CT scan, but I promise you, in the real world, it's just going to come more and more naturally to you every time you do it with a patient. Okay, hold on. Okay, so put that somewhere. So just knowing that contrast dye is very harsh on the kidneys, and we don't want patients with renal disease and also pregnant patients. We don't want them getting contrast dye because it can damage the kidneys of the unborn child. I told you, contrast dye is very hard on the kidneys. Okay, contrast diet is very harsh on the kidneys, so no patients with renal disease and no pregnant patients. Okay, next up, I'm going to ask you a question about MRIs. So, what is your number one priority for a patient that has an order for an MRI? No metal objects, very good. So, no metal objects on you or no metal objects on the patient or both? Both. If you're going to bring the patient there, if you're not bringing the patient there, then you're worried that you just want to make sure the patient doesn't have. But if you're bringing the patient to the MRI room and for any reason you have to stay with them, if you have metal in or on your body, you can't go. Okay? Very good. So, number one priority, remove all metal objects. And then you're going to do the MRI questionnaire with the patient, and you're going to ask them pacemaker, defibrillator, any implants, prosthesis, vascular clips, do they have any bullets in their body? And then finally, no pregnant woman because it will increase the temperature of the amniotic fluid and this can harm the fetus. So we don't want pregnant women getting x-rays because the radiation can harm the fetus. We don't want pregnant women getting CT scan with contrast because the contrast can hurt the kidneys of the fetus. And then we don't want pregnant women getting MRI because it can increase the temperature of the amniotic fluid. Okay, so in everything, in every imaging, in every surgery, whatever, your number one priority for a woman is to make sure that she's not pregnant. That's why usually when people get checked into the emergency room, one of the first things they do is ask a woman to provide a urine sample so they can do urine HCG, okay? A pregnancy test. And then if they want to be very accurate, they can do blood HCG, which is a blood pregnancy test. All right, you guys are doing so good. I can tell you're paying attention and I can tell that you're understanding. If you put all of, like I'm telling you, you're already very intelligent. So if you read the chapters, I mean, there's just no way that you're not going to pass. You are going to pass the NCLEX. Okay, the next imaging that we're going to, or diagnostic test that we're going to learn about is a lumbar puncture. So let me show you a picture. So lumbar puncture is when they're gaining access into the cerebral spinal canal so they can aspirate or remove cerebral spinal fluid so they can test it, okay? So what do you have to know for lumbar puncture? They're going in through the lumbar spine, L3 to L4, into the subarachnoid space, okay? So long story short, what do you need to know for NCLEX? Before lumbar puncture, the patient needs to empty their bladder. What does that mean? The patient needs to pee because we don't want them moving or getting up during the procedure. There is a needle that can possibly affect their spinal cord. So we don't want any chances of injury or trauma. Intra procedure, during, the position they should be laying in is called lateral recumbent. You want their knees to you want them to look like a shrimp. There's an even better picture I'm going to start using. Let me see this one. You want their knees to be up to their abdomen and their head down to their chest. You want them to make like a C with their body. Okay, so it's called lateral recumbent with their knees flexed to their abdomen and their chin flexed down to their chest. Okay, you want them to look like a little shrimp and they're going in L3 to L4. Okay, post procedure, they need to stay flat because if they get up too quickly, it's going to drop their blood pressure and give them a really bad headache. Lumbar puncture, before they need to pee, during lateral recumbent, after lay flat. Memorize those, you're good. Okay? Cerebral angiography, I've learned we don't really need to learn this right now. We can learn these same principles when we get to module 5 for cardiac cath. I don't want to overwhelm you. I want to stay focused on what's important. Next up is EEG, electroencephalogram. This is a graphic recording of the electrical activity of the brain before you wash the client's hair. Tell them that electricity is not going to enter their head. We're just measuring the electrical activity. No coffee, no tea, no caffeine, no antidepressants, nothing that will make them tired or stimulated. Post-procedure, wash their hair. Okay. Now we're getting into neurological assessments. Okay. So I want you to know, and I'm going to put a star here by it. Level of consciousness is the best indicator of neurological status. So neurological status is really not fair. I'm telling you, it's really not fair because all the other systems have a vital sign you can check or a lab level you can check to see how something is doing, right? It's not fair. The brain, and you know what? We have to advocate for the brain. The brain never gets it easy, man. Because if you want to see how the heart is doing, can't you check the pulse and the blood pressure? So easy, right? 1, 2, 3, you can check the pulse and the blood pressure, right? You can do an EKG. There's so many labs you can check to see how the heart is doing. You can even do a chest x-ray. You see how the heart is doing. For the lungs, if you want to see how the lungs are doing, you can count the respiratory rate. You can check the O2 saturation. You can listen to the lung sounds. If you want to see how the liver is doing, you can check the ALT, the AST. If you want to see how the gallbladder is doing, you can check the bilirubin. If you want to see how the pancreas is doing, you can check the amylase and the lipase. All of the systems, they have like a lab level or a vital sign you can check. But the brain, what can you check? You can't check a lab level for the brain. You can't do anything about a vital sign to check how the brain is doing. So you're like, how can I check on the brain quickly? You're going to assess level of consciousness, okay? And how do you assess it? Do you say like, oh, I'm going to walk in the room and if they look at me and talk to me, hey, they have a normal level of consciousness? Well, we're going to do something a little bit more standardized. Remember, in nursing, when something can be objective, that is the best, right? When I was in nursing school, like 13, 14 years ago, we used to use words like alert, drowsy, lethargic, obtunded, stuporous, and comatose. But then nobody knew the difference between obtunded and stuporous, right? And somebody could say, oh, you're drowsy, and somebody say you're lethargic. It was just too much room for miscommunication. So we started using this thing called the Glasgow Coma Scale, the GCS. Through this, you're going to determine a GCS score. The most accurate way to describe level of consciousness is by giving the patient a Glasgow Coma Scale score. Okay, so just like one of the most accurate ways to check and see if the patient has adequate cardiac output is you can check the heart rate and the blood pressure, right? Very quick, very easy. But one of the quickest ways to see, well, how is the brain doing is level of consciousness. And how do you calculate or describe level of consciousness? You use the Glasgow Coma Scale. The Glasgow Coma Scale goes from 3 to 15. Thank God, I think we're all a 15 right now. We're very, very blessed. A score of 8 and below means the patient is in a coma. Okay? You must memorize this. You must. There's no way around it. Okay? So this is the Glasgow Coma Scale. The Glasgow Coma Scale, you're going to assess the patient for 3 behaviors. How well they open their eyes, how well they talk, and how well they move. Eyes, talk, and move. If you go in the room and the patient opens their eyes on their own, for eye opening, you give them a 4. If they only open their eyes when you speak to them, you give them a 3. If they only open their eyes when you do noxious stimuli, like you press on their nail bed or sternal rub, that you give them a 2, because that means they only open their eyes to pain. If they don't open their eyes, no matter what you do, you give them a 1. A best verbal response. How do they speak? When they speak, are they oriented to person, place, and time? You give them a 5. Are they only oriented to person and place, or they're confused? You give them a 4. If they speak but it's inappropriate words, for example, you ask them, hello, how are you? And they say, well, uh, the butter needs to go in the fridge. That's inappropriate words for what you just asked them. You give them a 3. If you cannot understand what they're saying, you give them a 2. If there's no verbal response at all, you give them a 1. Then you're going to see their motor response, how they move. If you ask them to lift up both of their hands and grab your hands, and then they do it, you give them a 6. If they only move when you like press on their nail bed, you give them a 5. If they withdraw from the pain, you give them a 4. And then we have decorticate and decerebrate. Decorticate, they move towards their body. Decerebrate, they move away from their body. 3 and a 2 respectively. If they don't have any motor response, you give them a 1. So as you can see, the least that a patient can score in each of the 3 categories is a 1. That's why the least you can have is on Glasgow Coma Scale is a 3. Okay, so remember, it goes 3 to 15. 8 or less is a coma. I'm going to give you a moment to study this, and then we're going to do a question. This is very similar to something you might see, okay? All right, okay. So this question is annoying because it's split on 2 pages. So we're going to read it, and then I want you to calculate the Glasgow Coma Scale score for this patient. And then based off of that, you're going to tell me what you should do for this patient. And this question is a perfect example of if you do get a GCS score question on the NCLEX, like this is the perfect template. If you can understand this, you will be fine on NCLEX. Okay. The nurse is assessing the level of consciousness in a client with a head injury who has been unresponsive for the last 8 hours. Using the Glasgow Coma Scale, the nurse notes that the client opens the eyes only as a response to pain, responds with sounds that are not understandable, and has abnormal extension of the extremities. The nurse should, so I'm going to read each category out and you tell me what score would you give them. Okay, so for eye opening, they only open their eyes as a response to pain. So what score would you give the patient for eye opening? Very good, Nurse Jean. Very good. You got it. Okay. So for eye opening, they open it to pain. Okay. Next, it says they respond with sounds that are not understandable. So for best verbal response, what would you give them? He says the patient responds with sounds that are not understandable. You would give them a 2. Very good. So inappropriate, that means it's not appropriate for what you're asking. You understand what they're saying, but it's just not appropriate for what you asked, right? Like you said, you know the patient's name is Jack, and you ask them, "What is your name, sir?" And he says, "Butter." You understand what he said, but it's just not appropriate. Incomprehensible. Sabes upagako puan sa mulabzu. It's like they're mumbling or stuttering or saying words that don't make sense. So for best verbal response, because if you don't understand it, that means incomprehensible. Kopuan upaka kopuan salabzu. So you give him a 2. Very good. Okay. Um, and then he has abnormal extension of the extremities. That's for motor response. So far, Nurse Jean got it correct. Very good. So, in total, we said for eye opening. So, for best motor response, the patient has abnormal extension. What score would you give them for best motor response? 2. Very good. So, in short, let me see if I could make this, not this one, hold on. So in short, for eye opening, we said 2. For verbal, we gave them a 2, and abnormal extension, we gave them a 2 for motor response. So that means we gave them a score of 6, right? So what is the highest Glasgow Coma Scale score you can have? A 15, right? So like you and I, we are a 15, correct? So this patient is at a 6. So Is their neurological status within normal limits? Yes or no? They are in a coma. Very, oh my gosh. You've got it. Absolutely. They are in a coma because anything 8 or below is a coma. So now let's read the question again. The nurse is assessing the level of consciousness in a client with a head injury who has been unresponsive for the last 8 hours. So that makes sense. They've been unresponsive for the last 8 hours. So this score of a 6 now is not such a big surprise, right? What really should alarm you with Glasgow Coma Scale is if there's like a sudden change. Like your patient was a 15 in the morning and now they are a 6 4 hours later. That's a problem. Okay? But if their condition caused it and it stays steady, we're not as alarmed. We're going to keep monitoring and hopefully it will improve. Okay, so using the Glasgow Coma Scale, the nurse knows that the client opens their eyes only as response to pain, 2, response to sounds that are not understandable, 2, and has abnormal extension of the extremity, 2. The nurse should the nurse attempt to arouse the client, reposition the client with extremities in normal alignment, chart the client's level of consciousness as coma, notify the physician. Would you choose choices 1, 2, 3, or 4 if this was the NCLEX? What would you choose, guys? Only 2 people answered. Very, very good. The correct answer is 3. Okay, so let me put the rationale up for you. So the client has a Glasgow Coma Scale score of 6, so very good job. A score of less than 8 is 8 now, okay? A score of less than 8 is indicative of coma. While the nurse should continue to speak to the client, at this time the client will not be able to be aroused. The nurse should continue to provide skincare and appropriate alignment. So what we're trying to get here is a patient with a traumatic brain injury who has a Glasgow Coma Scale score that is not normal. Basically, we still want to speak to them. So if we're going to turn them, tell them, Mr. Johnson, I'm going to turn you, because usually hearing is the last sense to go. So they can still hear you. So even though the patient can't talk or can't open their eyes or can't move, please, please be respectful, be compassionate to them, because they probably still can hear you. Also, your other priorities for this patient would be airway, because remember, they can't protect their airway at this time. So make sure that their head is elevated so that they're not choking on their secretions. Also, skin breakdown. You want to be turning them every 2 hours because remember, they cannot turn themselves. So the correct answer would be 3, to document them as being in a coma. So we don't want to arouse them at this time, and we're going to learn next class why, because rest would be very good for this patient at this time. Rest is what's going to help to prevent increased intracranial pressure. Remember, module 4 is a lot. Next lecture is going to be very, very heavy, okay? Um, Also, we don't want to focus on realigning the patient right now, which was one of the choices, because they're going to keep doing that. They're going to keep doing the limb extension, um, because that is just like a natural brain response they're having to the injury. Long story short, let's switch to views. Long story short, no, not this one. Hold on. Long story short, the best indicator for how someone's doing neurologically is to assess their level of consciousness. The most objective way to say this is this patient's level of consciousness is to assess and assign them a Glasgow Coma Scale score. Okay? And you see the categories here. In the question we just did, because it was 8 or less, comatose client 8 or less, they are in a coma. And so we're going to document them as such. We're going to protect their airway. We're going to prevent skin breakdown. And we're going to continue to monitor their GCS score continuously. Okay. So next class is going to be very, very heavy. It's going to be a lot. We're going to start learning about the diseases of neurological system. And so it's not a lot of medications, but it's a lot of having to understand why the disorder happened and the symptoms that come from it. So next class is going to be a very heavy um, class that you have to read for, okay? So please make sure that you have read all of chapter 4 with a huge focus on neuro, okay? It's going to make understanding these diseases a lot more simple, and also it's a lot of symptoms to memorize. And then remember, as nurses, we treat symptoms. So once you understand why the disorder happened and then why the symptoms happened, you can then better understand what are your nursing priorities when caring for those patients. Also, next class, we're going to be doing a lot of questions. So each time we learn a disorder and how you treat it as a nurse, then we're going to do questions to follow up and make sure you understand it. And I'm going to say it one more time, guys. You're not going to believe me, but this is the truth. Module 4 is a lot. So please, please use your time this week. I wouldn't even worry about questions yet. Read chapter 4 and then you can do questions afterwards. Okay? All right, guys. So we're not going to jump into another subject yet because that's going to take too long. So make sure you read chapter 4, review what we've learned, and again, from what I'm learning, you guys are understanding the material. If you're not typing as much in class, maybe you're at work, I understand. But some of you, I think you're at work, but if you can start typing your answers, because that's getting me to see that this is a very, very strong class. I do believe if you read every week and when I assign you questions, you do them, I do believe that you will make it. God bless you all. I will see you next week. Thank you so much. Remember, your brain is more powerful than you know. You will pass. God bless you. Thank you.